So let's switch gears a little bit. Let's talk about ostomies. As you know, this is my area of expertise. I was a wound ostomy and continence nurse for many years, and I cared for patients with various types of ostomies. The good news is we're doing less ostomies now than we did in the past when I was a young nurse because we have newer surgical techniques which really spare the patient from having that body image altering surgery. However, there are some cases when patients will still have ostomies, and it's up to the nurse to be proficient in caring for a patient. You don't have to be an expert, but you have to know enough about it so patients trust you and have confidence in your ability to care for them. It's a very stressful time for patients. They're frightened. Their body system has changed, and now they need you to give them good teaching and good guidance in this area. So before somebody comes for an ostomy, if it's an elective surgery and we can pick out the site, that's the best thing to do. And ostomy nurses, ET nurses do this all the time. It's not always possible in emergency surgery or in trauma cases to have somebody pre-select the site, but it's optimum because this way the patient can see where it's going to be. We can make sure it's not in a fold or an area where there's going to be problems. There's many types of ostomy stomas. Anywhere in the GI tract you can have an ostomy. So the types of colostomies that you'll see go along with the areas of the colon. You can have an ascending, you can have a transverse, descending sigmoid, you can even have a sacostomy, which is not easy to care for. And any ostomy can be permanent or temporary. A permanent ostomy means that we've removed the rectum and the patient will have to have bowel movements for the rest of their lives through the ostomy. A temporary ostomy means that the rectum is still there and that the ostomy is only for a while to either heal an anastomosis from surgery, to reduce inflammation, to allow the patient to heal, and then the patient can go back to surgery, be reconnected, and have bowel movements via the rectum once again. An ileostomy is in the small intestines, the last part of the small intestines. And if you think about your anatomy and physiology, it's the colon or the large intestines that absorbs water. So your ileostomy is not able to absorb the water. So therefore, this effluent is going to be very, very liquid. It's going to look like a deep yellow urine in the beginning. And eventually it does become thicker. The body starts to adapt, and the patient says, as you look at them as they go through the process, it becomes like toothpaste. The big issue with this is it's very caustic to your skin. It contains gastric juices, it contains enzymes. So patients with ileostomies need maximum skin protections, and there's many types of products available to allow this to happen. Stoma is usually on the right side, because that's where the ileum is. However, you always want to double check because some patients could have had trauma and they needed to bring it out on the other side, but typically it's going to be on the right side. And it's usually a large budded stoma because it has to stick out a little bit so that the effluent doesn't get on the skin when possible. They have to avoid very high fiber foods. In class, I'm going to talk a little bit more about the foods they need to avoid. The big thing you have to worry about is dehydration, especially in the beginning. This is pouring out copious amounts of fluid until it starts to compensate. So therefore, patients will require 2,000 to 3,000 mils per day or more, depending upon if it's right after surgery. So patients typically will be on IV fluids, on PPN or TPN, until they can drink enough fluids. And as they start to get used to having the ileostomy when they're discharged, we need to tell every physician, every nurse practitioner, every healthcare provider that they go to, that they have the ileostomy because certain medications may not be absorbed appropriately and they may need to change what type of meds they're taking. Here's the foods that we're going to talk about to avoid with ileostomy. If you look at them, they're very, very high fiber foods. And what happens is, because they're so high in fiber, they can actually come together almost like a bird's nest and block the ostomy site. So therefore, we tell them to avoid these really high fiber foods. And sometimes if patients really, really have a liquid stool that never starts to get toothpaste consistency, we may tell them to use some of the foods that help to thicken their stool. Now, a colostomy, by the same token, again, can be located anywhere on the colon. The transverse is the area that goes across from side to side, and it's very hard to manage these in patients, and typically these are emergency procedures. They're typically not elective surgeries. Descending and sigmoid colostomies can be irrigated, and I'll talk about that in class a little bit. Patients can use any type of pouch that they want to. Some people actually get to the point where they know that they're having a bowel movement at 10 o'clock every morning after they have a cup of coffee and read the paper. So therefore, they may use a closed pouch. Some patients may wear no pouch if they know when they're going to evacuate, if they're using a irrigation system. and just wear a gauze pad or a small bandage. Less skin protection is needed because typically the stool that comes out of a colostomy is going to be formed and not very irritating at all. So here's some pictures of stomas, and as you can see, they're not all nice and round. It's the same way everybody's body is different. Everybody's stoma is going to be different. The first one on top there is a perfectly round budded stoma. That's an ileostomy stoma. But some of the other ones you'll see, some are retracted, some are flush. And these are challenges if patients have stomas like this and they need special care and special pouching systems. So what do you want to do? You just get a report from the OR and says your patient's coming back with a colostomy. What do you want to do? The first thing, obviously, is you're going to do all your routine post-operative checks that you do for any patient. But in addition, you want to check the stoma. It should be pink or red. It means it has good blood supply. If it's brown, if it's black, if it's blue, it means it doesn't have a good blood supply and it may not be a viable stoma. You want to notice the type of drainage because they're going to come back from surgery, either it's an ileostomy or a colostomy, there's going to be a pouching system in place. Now, if it's an ileostomy, the pouching system is going to be filled with that liquid stool because it's going to start coming out continuously. If it's a colostomy, typically it doesn't start to function because patient's going to have paralytic ileus after surgery, so therefore it's going to take 1 to 3 days to start having colon function again, so they may have some serosanguinous drainage. You want to note the type of stoma, where is it located, and is there any other pieces of equipment involved with the stoma? Is there bridges, rods, or stents? And I'll explain that further in class. You want to look at the peristomal skin. Now, when the pouch is on, you can't, unless you have a reason to, you really don't want to take off that initial pouch. But with the first pouch change, you want to check, how does the skin look around the stoma? Is it intact? Are there any problems here? This is an older thing, but some patients still hear about this. They try to put holes in the pouch to let the air out. It's not a good idea. The pouches are designed to be odor resistant, so that's not something we do anymore. And again, we want to do typical post-op care, especially we want to look at the fluid electrolyte status for patients who have ileostomy.